happy Friday. Welcome to our Assistant Outpatient Treatment Community of Practice. Thank you all so much for coming. If you received our email reminder, you know that we have Dr. Curtis Cummins and Jordan Byington here from Northern Lake CMH here to talk about AOT and the counties that they serve. So instead of our traditional, we have, they'll be giving us a presentation today. And so during that presentation, you'll be able to interrupt and ask questions. You can raise your hand. As always, we'll have a Q&A portion at the end. So feel free to chime in with your question or save it to the end. But we're going to have a lot of fruitful material today. And usually, you know, when we've done county profiles in the past, they can go anywhere from 30 minutes to 45 minutes. So we might have a shorter meeting today. Just depends on how many questions we have and how many questions we have. So before I kick it off, there's a couple of housekeeping items I'd like to make you all aware of. I make sure to plug this every single every single month, as you all know. So we have our Q&A sessions, our twice a month AOT Q&A sessions with Dr. Scott Smith. He's available to answer any AOT related question. It is a drop-in, so you can come anytime within that hour span. It's twice a month for an hour. This is also a great resource to share with families and loved ones of AOT consumers if they have, you know, a lot of questions that you may not be able to answer or want to, you know, delegate that to another person. We have that space available. As AOT gets more attention across the state, there's going to be more questions that arise and more clarification needed on certain processes. So please share this information internally and with community partners you may work with if you're finding that you or them need guidance around AOT. So in this next month, we have one of those weird months where the second Monday and the third Wednesday is on the same week. So that's going to be Monday, October 13th from 11 to 12, and then Wednesday, October 15th from 2 to 3. So again, if you have any questions, AOT related at all, please feel free to utilize those drop-in sessions and and share them out if you feel that that'd be beneficial. So yes. Oh, and also if you have any questions that can't wait until then, you know, you have my email. Yeah, you all should have my email. You can always message me with a question and I'll make sure to get that answered for you. So without further ado, we'll go ahead and introduce our guests. Today we have, like I said before, we've invited Dr. Cummins, Chief Medical Director, and Jordan Byington, Court and Hospital Liaison from Northern Lakes, CMH. So Northern Lakes is responsible for 6 counties. These counties are mostly rural with the exception of Grand Traverse. So we have asked them here today to discuss how they're implementing their AOT at their CMH and given their unique geographics and needs for AOT. So go ahead and take it away, Dr. Cummins.
Well, hey, thanks. Thanks, Olivia, and thanks everybody for participating. Great to see everybody. I see some familiar names on the call. It's great to see people again. So yeah, we have like a 20-slide PowerPoint that Jordan and I are going to go over. We're about 2 years into our kind of initial forays with AOT related programming. We're going to talk about just how we kind of got it going, you know, from really starting from scratch. I did want to give an acknowledgement to Dr. Spurlock's on the call from Northeast. They were one of the CMHs that really were informative to kind of how we kind of designed some things out of the gate and also along with CEI.
So I think Olivia did a nice job introducing us. So yes, I'm Jordan and that is Dr. Cummins. So she had also mentioned kind of where we're located. So Dr. Cummins and I are both primarily based in Traverse City, which is definitely, as you see, Grand Traverse County makes up for almost half of our population. At times that can serve a unique challenge because we want to, you know, be fair to all of our counties and our 4 different offices. But as you can see, Grand Traverse County is the bulk of who we, you know, almost half of who we serve. So how we started. So back in August of 2023, Judge Mack and others from the CBHJ came to Traverse City and did a presentation about AOTs. And I think it really was the right time for us to kind of kick some things off internally. We had some changes. Dr. Cummins, I credit completely because he was the one that really got this going, and it perked my interest pretty quickly. So luckily we've worked really closely together, to get this going. We definitely reached out to CEI, and like you said, Northeast, and just asking all sorts of questions, which I had tons we didn't know. So we also did this with no additional staff or funding. So these are both things that we just kind of took on in addition to already full-time jobs. But I think it was a space that both, like, it excited both of us and something we felt was really important. Initially, the first step, which was kind of basic, but it took a lot more time, and frankly, it took months, was cleaning up our electronic medical record. When I looked back, like I said, we have 4 offices, 6 counties, everything was different. So we had different people, all sorts of people across the agency were entering things. So it was just kind of messy. So that was something that we really went for to clean that up internally. We also then began reaching out to staff because I had a lot of staff just confused. And frankly, I had a lot of questions too. So quickly, we were put in the space of giving trainings to internal staff when I don't even think I always felt confident in what I was doing or what I knew, but it was a good space to kind of learn with our staff, I would say. Yeah, and
Great.
another thing was we were definitely like, and this is a challenge, I'll get to this in a little bit too, but with 6 different probate courts, 6 different judges, they're pretty siloed. So that was something, it was like, okay, well, this is done this way in this county, but this county does it a different way. I am still, I would say, going through that somewhat. There's still things that come up that I go, wait a second, this county wants it that way. But again, these are things we just had to start figuring out. Another thing we really started to change internally was back in my days on the ACT team, which was many years ago, but I remember it was this total chaos of, oh my gosh, this repetition date is here tomorrow. What are we going to do? They don't have an appointment. We can't find the consumer. So that was something we really wanted to change immediately. So we changed our practice and how we're notifying staff. We changed our practice on even just looking at the consumer's chart. You can see when that repetition date is. And that, I think, has been helpful across the board in making sure that if someone needs that second AOT or a continuing, that we're on top of that.
And I would add in, Jordan, as you were saying, yeah, we
Yeah.
weren't even renewing orders typically. So
No.
it was unless they kind of met that higher threshold that we thought we had to be, taking as evidence to the court for an additional AOT, or whatnot. So, and we were using nomenclature that was out of date. It was, NOLA was, using ATOs. That was, or rather, our electronic record was using old nomenclature. So really getting that cleaned up. So you kind of went over this a little bit, Jordan, but
Yeah, we've really leaned on others, and I can't thank everyone enough just for their time they've given us in different things. We've met with Judge Mack, who has been wonderful just in sharing his expertise, and same with the CBHJ. It's been, I think, crucial in developing and helping us move forward with what we're doing. So yeah, I talked about changing internal procedures, going through staff. We've given, trainings to staff at our regional hospital, Munson Medical Center, just trying to get that awareness to others we work with, of the changes that we've implemented and things that we are continuing to change.
yeah.
One thing that we also did, and we did with the assistance of the CBHJ, was these letters. These go out to every consumer who gets put on a deferral or AOT, even if it's a second or continuing AOT, we still will send these out. Just yesterday, I took a call from a gentleman going, I don't know what this is. I don't remember signing this. It was about a deferral agreement. And I found these have been really beneficial. I've said this before, but people are in crisis. I think a lot of times when they're in the hospital and they're going through this process and they get out and they've got follow-up appointments and they're back with family and all these different things. And I think this is often something that they might forget about. So it's been nice to send these out. And I would say once or twice a week, I'm getting a call from someone saying, what's this letter you're sending me? Or they're concerned, why are you involved? I want to go through my primary providers. So this has been a really good thing, I think, for our clients that we serve and our clients that are served externally.
Yeah.
We came up with all sorts of different letters. We are still, I would say these are still work in progress, but there's a list of certain ones we've done. This is our plan of service we provide to the probate courts. We intentionally made this one page, simple. We really have tried to simplify things as much as possible. We don't want our clients or our courts or myself getting, overwhelmed with too much. So as you can see, this is very basic, but I think it's enough for our probate courts just to understand what we are what we are providing to folks. This AOT monitoring form, this goes out to anyone who's on an AOT who's served by an external provider. Again, I think this has been something I will send an initial, just explaining that what this person is on the AOT, what that kind of means and what our involvement is. And I send a copy of their order. And then we also send this. Typically, we send this 3 times during the 180 days. And again, I think this has been helpful to some of our community partners. And then having them return it, as you can see, or maybe it's kind of small, I know, down at the bottom, so hopefully we can share this later, but you can see that then they can check boxes kind of what they think. And again, keeping it simple, we don't need to know everything that's going on with the person, but this gives us an idea of what they're seeing and how we can move forward.
So I have a question for you, Jordan, if I don't mind.
Yeah.
Like, how often would you say we're getting calls from external providers of, let's say, I'm not sure if this person should receive another AOT or not. I mean, do those calls come in very often where we're getting feedback?
Yeah, not too often. I would say we have one provider who sees a lot of our folks with Medicaid and Medicare. It's called Munson Behavior Health. It's connected to Munson Medical Center, and they're kind of one of our main primary partners. So I feel like at this point they kind of know what's going on, but it still is that dialogue, and I think it still gives them a chance to call us and just say, how can we better serve this person? I even had to talk with the VA in the last month with someone who was the AOT was going to expire and what this might look like. So I do think that it's helpful to them because it's something kind of in black and white from us and a copy of that order as well. I don't know if you
Yeah,
want to add anything, Dr. Cummins.
yeah, we do have a local VA primary care clinic that does have its psychiatry embedded. So that also covers our region as well. So as Jordan said, we are a CMHSP, but Munson Behavioral Health, Munson Healthcare is the local health system for Northwest Lower Michigan and the VA. So people might be getting care, from different entities. All right, this is you, Jordan. You know this slide.
This is me. So prior to taking on the court responsibilities, I was the hospital liaison on our crisis service team. I also serve as our team lead, so I still have my hand quite a bit in our crisis work, but yeah, so I also took on the court duties. So what that means is just being that primary person between 4 Northern Lakes with our 6 courts, entering everything in the electronic medical record, notifying staff, even though it's in, like I said, it's in the person's chart of when these orders are expiring, when the repetition date is, still notifying them, I find is something helpful. So I'll just send an email. Of court deadlines, I field quite a few phone calls, I would say, a month from either family or community partners that we might have that have questions that want to, talk about different things we're doing, kind of give their feedback. I've also been kind of the go-to person. So staff, will call and say, hey, what's this about? Or, just all different questions. I think it's been a good resource. And again, like I said, there are times I'm like, oh, I don't know, let me figure that out. So it's been a good learning for me. I've enjoyed it because I think this space is so big and so broad and things change. So I'm learning with them a lot of the time.
Great. So I'm going to take the next several slides here. So we're going to start kind of talking about data and how data can be really informative in terms of having an awareness of your own, like who are you treating and what does that data look like? I find this to be really, really interesting. So back to when we kind of started to kind of build out our kind of AOT program, we needed to have an awareness. Yeah, I quickly realized to really make sure that our electronic record can be a good tool to help us kind of build some of this scaffolding out. So our EHR is probably people know have heard of Peter Chang Enterprises, or PCE, based in Farmington Hills. It covers about 98% of CMHSP lives across the state. And each CMHSP, the pros and cons of this, of course, has their own agreement with PCE, and they kind of then tailor their local PCE product to best suit their needs. So ours is called NOLA for Northern Lakes, and something we all voted for way back in the day. So we've been in this record system for about 6 years. And court order functions are embedded as part of the electronic record, which is nice. And as I mentioned before, we kind of just had to kind of clean up some nomenclature, like there were ATOs and things that weren't even applicable. So of course, with the new state law back in 2018 or so, we have new tool or new nomenclature of AOT, of course, and then the various kind of durations of those various orders. So we just put it in our request with our IT team here internally that linked with PCE. We're able to kind of get those changes modified within about 2 months, which is great. That kind of got us rolling. So that way we could start getting some initial data to understand, like, how many do we have? Because we actually had no idea. We had zero idea of how many people we were serving that were under deferrals or court orders. So as part of that, we're able to then start scaling out. Now we have our nomenclature kind of updated. We can start kind of building some reports. So this is just a snapshot of kind of the various things we can look at internally using Power BI, which is a Microsoft product that's very easily used to kind of build out reports and then kind of draw down data like overnight. So we can, as you can see here, is my cursor, by the way, on the screen, or is it not? I'm curious. Is it? Okay, that's good to know. So we can pull things like, I'm going to share this order on consecutive orders. We can pull information down on that. We can pull no-show information. We can get granular data on like what programs are people open to. We can kind of get trend data about how, are we seeing more people on orders versus, let's say, the year previous. And we can get a lot of information, NGRI information. We can get no-show rates, as I mentioned before, and also information regarding what kind of medications are people receiving. So really, really interesting. So just kind of getting into it, this is something I just created. I just pulled this down yesterday. So at Northern Lakes, we directly serve about 100 people. I'm sorry, within our region, there are about 100 people on AOTs across our 6-county region. We directly serve about 2/3 of them. So that's the lighter color, 66 out of 100. So a good number of people are not directly served by us that are on AOTs, which I thought was interesting. It's about 2/3. So as Jordan shared, that could be at Munson Behavioral Health, could be the VA, could be private practitioners. Pine Rest has a local clinic here in Traverse City. So it could be a whole array of people. Of course, as you know, people have the choice of their provider, even if they're on an AOT. And then in terms of deferrals, we have about 50 people in our 6-county area, and we directly serve about half of those. So we're not as involved as much on people on deferrals. And then this is just a snapshot. Again, I pulled this down yesterday of like, okay, what does that data look like with the AOT data that we have? So beginning at 12 o'clock, this first teal color is first AOT that typically somebody comes out of the hospital, 60 days of hospitalization, and 180 days of outpatient treatment combined. So one thing I talk about is nomenclature is really important with AOTs. We have combined orders that include hospitalization, and we also have AOT only, which is outpatient services. So if you break this down, we have about 40 people out of 100 are on their first AOT, but as you see, we have people on second AOTs or continuing, which could be third or fourth or fifth AOTs. And this yellow slice here are the typically 365. Those could be people found at the state hospital who are being discharged to the community from the Center for Forensic Psychiatry. So a fairly high number of people who are on orders are coming to us from those facilities. And then we have and these smaller slices here are AOT onlys that we are typically, if we do see people that are getting an AOT only, usually it's a step down from an existing combined order. So that's just, that's where we are right now. This used to be a much smaller slice of AOT only versus the whole, we used to have maybe less than 5% of people on AOT onlys out of the total picture, but that number is growing as we kind of recognize the use of how we can use AOT only as it's a good way to step people down, but also, make it easier for somebody maybe to engage in treatment and not necessarily feel like they or have hospital days maybe looming over them. So I wanted to actually talk about this. I created this slide yesterday with some assistance from ChatGPT, so I will acknowledge that. But I was kind of in a crunch. But I wanted to talk about the role of consecutive orders, just kind of to get on a soapbox a little bit to speak about the evidence and why the length and continuity kind of matters. Because I shared in the beginning, we weren't really continuing orders at all. I mean, it was pretty infrequent. And the evidence that this kind of pulls from is from New York State Kendra Law Studies. They've been doing things in New York for decades, like almost 20 years, I believe. But some of the challenges with AOT data is that obviously we're not doing randomized controlled trials. It's observational data typically. But what we do know is what the evidence shows is that having orders of significant duration, 6 months or longer, is better, and that the intensity of what services are being delivered under an AOT are important. How intense are the services? Maybe intensive case management. What kind of engagement? That's really important. And compliance with AOT program is important. And how are people succeeding or not succeeding with care? And then this fourth box is, again, what I'm speaking to is renewals or consecutive orders. Sometimes people might need several years of AOT treatment to kind of really hopefully develop that insight into the need for treatment so that they engage in care if needed on a voluntary basis. And ideally, of course, the people that then, if they're going off an order, typically they need to continue that treatment. So hopefully they continue to engage with us or others. So I just wanted to kind of share that. As a follow-up, I wanted to kind of share what is our data with consecutive orders. So again, I created this slide yesterday. So we're looking at here is consecutive orders, consecutive AOT orders, but taking out the NGRI population. So obviously people who are NGRI can be NGRI for up to 5 years that require successive AOTs, So I was really kind of curious in looking at this data. And this is not people that we directly serve, but also people that may be served in the community. But if you can see from this graph here, obviously a lot of people end up with first orders, but there are a good number of people who are getting second orders, third orders, even a fourth order, again, who are not NGRI status. So I just wanted to kind of share that. Like, we are really, if we feel like we need to kind of continue these orders to continue to best serve somebody, we will petition the court and provide a clinical certificate and then, have a judge make that decision. So I just wanted to kind of share that. It's something that I could share 2 years ago. We definitely were not doing this. So I just wanted to kind of spread the word on that. And this is just a slide I created before. At Northern Lakes, we are a little bit different. We actually, the treating psychiatrist is the person that will then examine the person and go to court and provide testimony for any additional AOT orders. So that's something that we do at Northern Lakes. I've heard this on various calls. Sometimes there's a challenge of, maybe if they're seeing somebody else that's maybe not part of the direct care team, that somebody might miss their appointment, and how do you get that person in for an examination before the order expires? And I just personally, this is my personal thoughts, like our staff are able to both treat and develop rapport and educate who they're serving, and also if need be, then provide that evidence and testimony to go to court. So I feel like we can walk that walk with that person as they kind of continue care. And I think it's worked out really well. And an advantage of that, it kind of doesn't make it another complicating step to get that additional examination, because if they, let's say, I might try to see somebody maybe a month or so before their order might expire. If they happen to miss that, well, I can still complete a clinical certificate based on my previous visits with that person from the past, say, 6 months or 2 months. So what this really form shows is that, even though I may not have seen, Joe Smith, who I think needs another order, I will lean on my testimony from 2 months prior. And that's always been admissible in court, at least in our 6 counties. So anyway, just a little bit of twist of how we're doing things at Northern Lakes. Keep it simple, and also kind of be able to kind of, potentially provide that care and be that person that does go to court if it feel like we need to. This is a slide on terms of who are we primarily treating within, this is for our AOT and deferral data that we are directly serving. And this is just created this past week. And this is about 90 people in total. And this is a pie chart. I'm not sure if it's coming through, but the largest pie slice here is people with a schizophrenia spectrum illness, schizophrenia, schizoaffective disorder, unspecified psychotic disorder. So that's kind of who and this is what you want to see, right? With AOT, we're treating our severely mentally ill individuals. And so we have about 2/3 of people on AOTs or deferrals, have a thought disorder. The next largest slice is bipolar disorder, so bipolar spectrum illness. And then there's a smattering of other things that are still under that. But I just wanted to kind of show, I kind of feel good that at least we know we're capturing the right population for people who are on AOTs or deferrals. I just wanted to kind of share a slide on use of LAI, stands for long-acting injectables. Maybe people know what that term means, but medications that are usually used to treat schizophrenia, spectrum illness, sometimes bipolar disorder, but they're really an effective tool. This is a complicated slide, but I wanted to show like what's the role of LAIs for use in people with severe mental illness and if they're on an order or not on an order. On the left side here is really kind of looking at people who are on an AOT or deferral and have a schizophrenia spectrum illness. About 60% of those people are receiving an LAI versus not receiving an LAI. And on the right side, really, it's that same population, but not on order or deferral. And about 33% of our individuals with that schizophrenia spectrum illness receive an LAI. So we're actually already leaning into LAIs, regardless of an AOT or not. Something we've been doing for a long time at Northern Lakes. So we deal with when we're in a rural part of northern Michigan, so sometimes it can be a lot easier for someone to come in every month, 3 months, sometimes every 6 months for their treatment and get stability. So just wanted to share that bit of information. This is my last slide, then I think Jordan's next. So really, we're kind of on the cusp of like, we have a lot of good information internally at Northern Lakes, but how do we then start working with external partners? That's going to be the next evolution, I think, for us as an agency. So working with community partners on AOT programming, and how do we design that system? So I'm looking forward to working with others that know this stuff better than I do or than we do. We're to interface with law enforcement, hospitals, private providers, but information sharing is going to be part of that. I'm not sure what that looks like yet. So I'm excited about that. Some questions that I have though is like, what information is relevant? What do we need to share? Is there the risk of potentially, you've heard Jordan and myself speak about trying to keep things as simple as we can, because obviously AOT programming, as we already know, is relatively complicated. So I've learned from others just on all these various calls, it's a complicated process. I mean, there's a lot of pieces that I don't know. So what are our next steps? I'm not sure, but I look forward to it. So you're up next, Jordan.
Yeah, just to go over some challenges, and I imagine this is, many of us feel this, but initially there was a lack of who to look for programming. That was something that we had to kind of go through. One challenge I experienced quite a bit is the 6 different counties, 6 different judges, 6 different law enforcement, 6 different, there's 3 different hospitals. I mean, just different things. It's challenging, especially when we're on calls and hearing about things. Like, one thing is status conferences. That's something that kind of, it really intrigued me and is something I wanted to push. And I've had 2 of our courts say, no, that's not something we do here. So just challenges in kind of moving things forward. We seem to be, because we can be kind of a touristy place, very touristy. People can sometimes kind of blow in and blow out of our area. I'm sure this happens everywhere, but people leaving our area without notice. How do we find them? Tracking them down, those things. Sometimes we run into challenges not being able to communicate with external providers. We have 2 that do provide services to a few of our folks that just, for different reasons will not really speak with us. So that's been something. Folks coming to the emergency room department that we maybe won't screen. So maybe they have private insurance and they're screened by different social work, and then we're not notified that they were even assessed and then discharged. I think a challenge that we, Dr. Cummins and I have myself, is just time. And I feel sometimes I could spend my whole, full 40 hours a week doing this, but that's not possible. I still have a lot of other duties. Dr. Cummins didn't mention, but he's been our interim CEO for the last few months. So if you can only imagine, he's had the CEO hat, medical director, just very taxed at times. He's done amazing, but still, it's just a lot. And I think sometimes we both want to give more to this, but we just can't. And one thing we're really struggling with, and I know I'm struggling with even professionally, is right now we're under cost containment. We've had quite a financial situation at Northern Lakes. And so we've really kind of, I guess I would describe it, closing our doors, right? So folks without Medicaid who might have private insurance and, saying, hey, they can be served elsewhere. And while that is true a lot of the time, sometimes I'm really feeling like I'm having to fight, saying, no, this person really needs our, the services that we can provide. But we also have had some successes, right? I do think we've really changed the culture at Northern Lakes and with staff. Even just I've heard through the 2 years, just staff using more, I don't know what you'd say, but correct terminology. We're not hearing ATO anymore, just different things. It's I think we've had a good relationship with a lot of our community partners, and it's had us communicating more than we previously were. I think it's been a better for our clients that we serve or served elsewhere, because I think there's more information being shared with them. We are keeping a closer eye on folks. Concern I really had in the beginning was these people weren't really being monitored, and what if something happened? Even when, I don't know if many of you are aware, but we had a pretty serious incident here, stabbing at the Walmart in Traverse City. And my first thought was, okay, is this one of our folks, and what have we done? And it was just, I think though, seeing that we're reaching out to them, we've reached out to their providers, we've sent letters, like we are trying to engage these people. So we're still drafting our own policies. That is something that I think keeps evolving. Yeah, I don't know if you want to add anything there, Dr. Cummins.
No,
Just one success story, and then I'll be quiet. We had a gentleman, this is kind of a unique case. So he was NGRI, I think was a discharge directly from the forensic center, if I'm remembering correctly, I think. He does not qualify for Medicaid. He will not. So parents really did not want him discharged to like an adult foster care home, which was the recommendation. So he got discharged to a residential facility, which isn't something we typically would do as at the CMH level, but they were able to fund it. So he was there a couple months, psychiatrist there. We really tried to engage, saying, hey, this person's NGRI, he needs a second AOT. They did not want to do that. So we were concerned, family was concerned, but essentially it got dropped and there was really nothing we could do about that. But when he got home, we were able to really wrap around him with our ACT psychiatrist and with Dr. Cummins, doing those 2 clinical certs and getting him back on a combined AOT. So it was clunky and it was a learning process, but I really think that it ended up the best case for everyone involved in ensuring that we can treat him the best way possible.
Wonderful. Thank you both so much for taking time out of your busy schedules and letting us learn from you and hear about what y'all are doing. It's just been extremely fruitful. So I had a couple points that I had thought of when you were presenting. First of all, when you showed the letter, I don't know if you saw, but when you showed the letter to consumer, like the chat blew up and everybody wants a copy of that letter. So yeah, if it's okay with you, y'all can send that to
Absolutely.
me. I might already have it, but
Yeah,
I can send that out.
I'll email that to you once we're off of this. Yeah, that's great.
Okay, wonderful, wonderful. And I just wanted to also say, we if you registered for the COP, then I do have your email, and you do have, if you receive those follow-up emails and those reminder emails, then I do have your email. But if you don't receive those, then I do not have your email. So either email me directly if you want to get on that list and make sure you're getting the follow-up materials for the COP, or just drop your email in the chat and I'll make sure to add you to that. So wanted to say that also. I also love that you ended with that success story. I think it's super important to celebrate the successes in AOT, and that in itself can be kind of a vexing, topic to even think about. Like, what does success look like in AOT? Like, how would you define success? So I really appreciate y'all touching on that and ending on that note. So I had a question of my own, but I wanted to open it up first and let folks ask a question if there was one. So I don't think we had any questions in the chat. Just lots of praise and begging for that letter. So yeah, I'm gonna stop talking now. And if anybody has any questions for Dr. Cummins or Jordan, feel free to come off mute.
So with that silence, I'll share that. I'm not sure people have an interest in data, but we have a great IT team at Northern Lakes. I mean, I really want to let them, if there's a role for helping, if you're working with the CMHSP or other, it's incredible what we've been able to do. So I just wanted to kind of share that. Specifically, Rob Veal, I think, might be on the call. He's been fantastic, has great expertise, and can do really magical things that are really impactful, I think. So we are happy to support any CMHSP that's out there.
Yeah, thank you, Dr. Cummins. This is Carol Doherty from North Country. You've been greatly helpful as we're building ours. I do have a question though for you. Do you negative cert to end an order or do you let it expire?
So in terms of, if we want to end an order early, yeah, we can notify the court if well, we haven't typically done that. I mean, I know that's something we can do if we feel like you need to end an order early. So, so I can't speak specifically on any cases that we've done, but I think it'd be just notice to the court. I think there's a form that we would send a letter to the court, right, Jordan? Have you encountered that at all?
Yeah, no, I have not had us, with a psychiatrist say, this person no longer needs this order. So we haven't run into that. And then when it's expiring, we just let that expire if we don't think they need an additional order.
We're just currently discussing if we need to be that formal or, that's Dr. Vogel's she's trying to figure that out.
I can
Well,
share that Judge Mack has shared multiple times to just send a letter to the court to notify them. And in my experience, I've had it happen during 6-month review reports that when the psychiatrist completed the 6-month review, they checked the box that they did not believe the person still was a person requiring treatment. And after that, I filled out a petition for discharge and submitted that to the court with that 6-month review.
Thanks, Jenny.
Mhm.
yeah, that speaks to a lot of those forms that are out there that I'm not even aware of. I heard of them, but I can never remember them. Like petition to discharge, that's an important one, but we've not used.
We didn't mention this, but I will add one letter that we created was a no longer monitoring form. And that is something I use pretty often to our courts, especially when like we had someone who came in from Massachusetts, right? So this morning I'm sending a letter to the court saying, hey, this person's back in Massachusetts. We really don't have a way to be monitoring this. So that has been a form that I don't think it initially I thought was like had that much importance, and I use it all the time of just informing our court, hey, this is what's going on with the person.
So, kind of along with that, I know that different counties have been wanting to, have had similar ideas of wanting to create letters or create forms to be able to send to the court, but may not necessarily know that that's something that they can do or that the court would accept it. So, did you have any, I guess, issues in terms of creating like these letters and forms of the court accepting them, or did you run into anything in that respect?
I don't know, Dr. Mrs. Okay, take this one. So we have a pretty tight, I would say, and positive working relationship with our judge in Grand Traverse County. We meet with her pretty often, so we definitely have leaned on them. Um, and run things by them at times. Not to say our other courts aren't as important, but again, we're just trying to keep things simple. And it really has seemed our other courts have been very accepting of anything. I think because there's been so much more communication than there had been, they've welcomed, anything that we've done really in that space.
Great. So I see Jenny in the chat dropped a question. In what specific challenges did you have in monitoring 6 counties, and how have you worked to address those challenges?
I'll have you take that, Jordan. What do you
I'm
think?
just gonna say, I don't know, I feel like I keep chatting.
No,
Yeah.
you're good.
And do you mean with our clients or with the different courts?
So I'll say one of my questions was about the courts and the law
Yeah.
enforcement, because I know that that is something that not even just with CMHs who do preside over multiple counties, but when you're working cross county and when you're working with other probate courts, there are challenges in what is expected of you and what the court wants. So yeah, I was wondering if you had like specific examples of navigating like court by court, and kind of same question with law enforcement.
Yeah, so one I mentioned was those status conferences. That's something that some of our judges have been willing, to entertain, and others like that's not something we're going to do here. Just a silly one, but one was a court frankly demanding that we have someone in person for every court hearing, and it's in one of our more rural areas. It's just not feasible. We don't have the staff. So we've offered, saying, hey, we can be there via Zoom. But that wasn't as accepting. So we really kind of had to go back and forth. We spoke with Judge Mack. I mean, it really was more of a challenge than I would have thought. And even with different prosecutors, we've had different interpretations. Some judges, I'm very grateful to our one in Grand Traverse County, and I could, and some of our other ones as well, who are willing to meet or have like a standing meeting with us. We've had another judge that just will not talk to us. They say that is, essentially, I can't remember the word she used, but basically we'd be violating like the clients and talking, and we really weren't trying to do that. We were trying to talk about maybe some challenges we've had and get a better understanding of how they're interpreting language versus how we are. Same with law enforcement. In the 6 counties, they have different, some require a transport order, some will just accept that AOT if box 16 is checked. So just different things, and it can be a little frankly overwhelming. I have notes, that I've come up with of how they want things done. Getting someone picked up who's on an AOT, like I just mentioned, it's all very different. Some, the court will give us the forms we need, then we'll take it to the police. Others, we can just go right to the police. Others, the court will take it to the, it's just really different. And it's just this, ex parte communication. I'm so sorry, Jenny, it was escaping me. But yeah, and again, we weren't looking to talk about a case currently on the docket. We just were really looking to kind of communicate and come to a better understanding. So that's been a challenge. We've had a new judge enter in Leelanau County during our time, and we've been trying to meet with that judge for months now, right? But everyone's so busy, it's just hard. So I'm grateful to all of our courts and all of our court staff. I'd give a huge shout out. They've been really wonderful at times, but even when they're giving me the message, no, the judge will not see you. So you got to try to keep those relationships as positive, even when it's challenging. I don't know if that answers some of that, or if you want to add anything, Dr. Cummins.
No, you summarized really well. Yeah, I mean, some courts, it's really great, open flow of communication. How can we help you? And other places, it's a wall,
Mhm.
But
Yeah.
Grand Traverse County is where the majority, probably about half of our court activities occurring, and that's where we have the best relationship, which is fantastic. We're just hoping to kind of scale that out
Mhm.
to kind of maybe influence how practices is we're geographically and politically at a very interesting place. Like Grand Traverse County is kind of a purple county surrounded by a lot of, I don't want to say a lot of red, but there is a lot of red. So anyways, that can, and sometimes maybe, even though this shouldn't be political, right? Treatment of mental illness, but it's interesting how it shakes out sometimes.
I'll add to like one of our counties, the language they use in calling like the mental cases, like that's been really just something I hadn't encountered before working with it. Kind of like, oh, that's not how we, but you kind of got to dance with them too and not come in too strong, because I do want to preserve and improve that relationship.
Mhm. Mhm. Well, that's great. Did anybody have any thoughts? Anybody else have any thoughts? Any similar experiences? I won't call anybody out, but I know a lot of a lot of folks from different counties on this call can definitely resonate with those issues with the court.
I can share that we are probably going to ask Grand Traverse County has some cannabis or marijuana related tax funds. We're going to make a request for that to maybe help scale out some of our AOT programming. That's something for people in terms of how do you fund this. That's something that's, those dollars are out there. Earlier this year, the state kind of put out that information. So that's just a thought for people to explore if they feel like they need to, potentially seek funding. That could be a potential source.
Yeah. 100%. I also like that y'all touched on LAIs and the information that you gave about that. It made me think of Washtenaw County, who has in the last couple of years partnered with their like local pharmacies to help administer LAIs. I thought that was really cool when we found that out, and very innovative, and just to improve overall accessibility of LAIs. I thought that was really cool. So I wanted to, yeah, give a shout. I don't think anyone from Washington is on the call right now, but I just wanted to give a shout out to them because I really
We're here.
appreciate that practice.
Hey,
Oh,
Tina.
Stephanie. Sorry, Stephanie. Hi.
Quiet today. That's okay.
No, that's okay. Yeah, I just wanted to give you guys a shout out.
Thank
It
you.
looks like, yeah, of course. It looks like we have another question. How has data helped you with the decisions or processes for your AOT programming? And what would you recommend a CMH collect data on?
I'm gonna punt this Dr. Cummins, but I want to add one thing in the beginning. I know that our courts have approached us, a few of them, saying, whoa, we've had a huge increase in cases. And we've gone back and kind of said, okay, are these new petitions or are these more the second and continuing AOTs? And so I think just having our data to say, yes, this is why you've seen an increase in the second and continuing is because we've changed our practices. So at least for me, that was helpful to be able to explain to them, you know, one piece of why they're seeing an increase. Sorry, I didn't mean to cut you off, Dr. Cummins.
Not at all. Yeah, this is a great question. So these are just thoughts off the cuff. One, I think it's just helpful to have just an awareness of like, okay, who are we, who are we serving? You know, what kind of care are we providing? Granted, and it can go to external partners, right? So it's always just helpful to know, like, okay, we're obviously CMHSPs are responsible per mental health code to monitor, right? AOTs. That doesn't necessarily mean you're delivering the care, you are monitoring, and we're doing that. So it's just helpful to maybe have that information. In terms of processes, I'm just thinking about that. It hasn't really impacted our processes per se, but it can maybe be helpful because in terms of how we deliver, like if you're a single county CMHSP in an urban area, you might actually have a specific AOT team. We don't. We actually we have offices in Traverse City, Cadillac, Houghton Lake, and Grayling. So one larger office, Cadillac's also fairly large, but then two smaller offices. So we really can't have an AOT located in each office. But we were able to kind of get a sense of caseloads and are people getting what, obviously we have 3 ACT teams as well. So, but we were able to kind of, localize at least with some information on data is how we build our service array. And we actually have a specific AOT case manager in Traverse City, but we can't replicate that in the other offices. We might just have one case manager in Houghton Lake, one case manager in Grayling, because that person is doing all care, including AOT. So that means we need to make sure where do we target our training for the workforce. So data can help just a little bit with that. And what I can share is that it is kind of helping. The data can be, and our data kind of started from 2023 early. So like with that consecutive order data that I shared, like this you can see how practices are evolving because AOT is an evolving practice. I think Michigan is kind of at the forefront along with New York State and North Carolina based on my awareness of, kind of advocating for that. And, AOT, right? AOT only orders are a pretty small slice, I think, of AOTs statewide, but we can kind of start even tracking what that looks like here at Northern Lakes, but how do we compare maybe with another CMHSP that maybe has met more AOT orders? So you're able to compare practices across CMHSPs and across the state. So I think it's really neat. I'm actually interested. I've done some digging on, where is AOT only really taking off potentially, and what's happening? Are they maybe stepping people down, or are they people who are really new to care? And being brought into the system. So it just allows for communication, and I think data can help inform those discussions. I'm not sure if that makes sense. I'm just kind of meandering, kind of free association here, but anyway, it's Friday.
I think that makes sense.
That was a lovely answer. Thank you, Dr. Cummins.
Okay. I did have another thought about status conferences. I wanted to, touching on status conferences real quickly, it made me think of how I know that a lot of counties are wanting to implement status conferences in their area. We do at the CBHJ have information on status conferences, and I think that we have done a community of practice before on status conferences, so you can find that on our toolkit. Also, I believe if the current legislation that is pending passes, I believe language about status conferences and that being a practice for judges will officially be in the mental health code. So we're hoping that that promising practice will, like being validated by being in the actual mental health code, it might get some traction. So if you have any questions about status conferences or how to implement them in your county, different things like that, let us know. You can email me directly or but yeah, I'm very pro status conferences. I love status conferences. So whenever I get to talk about them, I jump in. So. Okay, did anybody else have any questions? No.
Well, thanks for the opportunity for allowing us to share, and
Yeah,
great to see some new faces and some familiar faces.
yeah, of course. Thank you both so much again for coming. It really means a lot. And yeah, we'll make sure to include the PowerPoint and the letter to consumer in the follow-up email. And if you have any questions about that, email me and yeah, I'll get back to you. But otherwise, thank you all so much and have a great rest of your Friday.